Hello everyone, this is Dr. Chandana Vishwanatham. So today in this video, I will be talking about respiratory system for MRCP part 1 and part 2. If you have not seen my previous videos, please go through them and come back to see this video. In this video, we will mainly focus on the asthma guidelines. I am making these videos mainly for people who are not affordable for the expensive online courses. So I will try to cover everything, and as much as possible I'll try to complete in my videos, but it takes time to make these videos, so please be patient and stay updated. Subscribe to my channel. I take that as an encouragement from you to make more and more videos which are free of cost. So let's start today's session. So as for asthma guidelines, there are two things. First one is NICE guidelines 2017 and BTS guidelines 2016. NICE stands for National Institute for Health and Care Excellence, whereas BTS is British Thoracic Society guidelines. So the NICE guidelines are followed for management of asthma patients, whereas BTS guidelines are preferred for management of acute asthma patients. So coming to the NICE 2017 guidelines, there are four important things that you need to remember. The first one is clinical assessment. So this is the clinical assessment. They divide the patients into three groups: adults, young people, and children. So adults is nothing but 17 or more years of age, and young people is 5 to 16 years of age, whereas children is less than 5 years of age. So all the investigations and management, everything they divide the patients into three groups based on their age. The second one is investigations list and the diagnostic summary. That means what are the tests that are needed to confirm the presence of asthma. There are some investigations that you need to know about. The third one is diagnostic algorithms. In children less than 5 years of age, it is mainly of clinical judgment because objective tests can't be done on those children. So diagnostic algorithms are available for children and young people aged 5 to 16 years, and a diagnostic algorithms for adults aged 17 years and over. So this is important for MRCP. You won't be asked on the children and young people algorithm. Adults algorithm is important. And coming to the management guidelines, suspected asthma in children under 5 years, newly diagnosed asthma in children and young aged 5 to 16 years, and newly diagnosed asthma in adults aged 17 or more. So this last one is important for us. And going to the first one, first one is the clinical assessment for adults, young people, and children with suspected asthma. So, as you might be knowing, these symptoms, the presence of wheeze, cough, or breathlessness, any daily or seasonal variation in these symptoms, you have to ask about the triggers, personal family history for atopic disorders. But based on these symptoms alone, without any objective test, we can diagnose asthma. This is one point mentioned here, and we have to, after taking the history, we have to examine the patients with suspected asthma, and we usually find expiratory polyphonic wheeze, and we have to look for any other causes of these respiratory symptoms, and then also you will be suspecting the patient of asthma, but you never diagnose the patient with the clinical history and examination unless the patient is a child under 5 years. Under 5 years, the objective tests are difficult to do. So the symptoms and the based on observation, clinical judgment, and regular follow-up, the patient will be diagnosed and treated with asthma. But once the child is 5 years and child is having the symptoms continuously, the child will be considered as a patient in the group children and young people aged 5 to 16 years. So there are two algorithms for children and young people aged 5 to 16 years. There is algorithm B for objective tests. For adults aged 17 years and more, we have to rule out one main thing, that is occupational asthma, by asking symptoms if they are better on work days, away from if they are better on work days, or they are worse on work days. which helps to diagnose occupational asthma. And if that is not suggestive of occupational asthma, then we have to go for algorithm C for objective tests for adults aged 17 or over. So I have taken these directly from the guidelines. So there are some objective tests that you need to know. The first one is obviously obstructive spirometry. As soon as you suspect asthma, you have to do spirometry, and the positive test threshold is same for adults, child, and young also. So FEV1 by FVC is less than 70% is a test that helps to diagnose asthma. And the second one is bronchodilator reversibility. So this bronchodilator reversibility test is done by measuring the FEV1 before giving the bronchodilator and measuring the FEV1 after giving the bronchodilator. So in adults, improvement in FEV1 of 12% or more and increase in volume of 200 ml or more is considered to be suggestive of asthma. And in children and young, improvement in FEV1 of 12% or more is considered to be suggestive of asthma. And the third test is fractional exhaled nitric oxide. So this test measures the level of nitric oxide in your breath. So there is something called as inducible nitric oxide synthase, which during inflammation increases, and there will be formation of nitric oxide because of the inflammation. So this nitric oxide which is expired will be measured, and for adults it is 40 parts per billion or more is suggestive of asthma, and for children and young people 35 parts per billion is suggestive of asthma. The fourth investigation is peak flow variability. If the peak flow variability is over 20%, it is suggestive of asthma for all these three. So adults, child and young, the variability should be over 20% to uh, diagnose or to suggest the patient that to suspect the patient to be having asthma. None of these tests are diagnostic. There is a diagnostic algorithm including these tests individually. So these tests can only suggest diagnosis of asthma, but a combination of these tests, uh, we have to put them into a diagnostic algorithm. Only then we can diagnose asthma. So there is another test called direct bronchial challenge test with histamine or methacholine, which is bronchial hyperresponsiveness. For children and young people, it is not applicable. This test is not done. For adults, a propagative concentration of methacholine causing 20% fall in the FEV1 of 8 mg per ml or less is suggestive of asthma, but this is not usually done. We will go to the diagnostic algorithms. As I told you, children less than 5 years don't have a diagnostic algorithm. They are treated based on clinical judgment. So there is a next algorithm is algorithm B, which is for people aged 5 to 16 years. You won't be asked questions on this algorithm. So we will directly go to adults algorithm for diagnosis of asthma. So as soon as you suspect the patient to be having asthma and the patient is aged greater than 17 years, we have to do a spirometry. So if the spirometry is showing obstruction, that means the FEV1 by FVC ratio is less than 7. If it is less than 70%, we have to go to this side of the algorithm, and if it is not showing any obstruction, we have to go to this side of the algorithm. So the next thing that you do is the bronchodilator reversibility. If the bronchodilator reversibility is there or not there, in these two conditions we have to do the other two investigations, that is fractional expired nitric oxide levels and peak flow variability. So if there is a reversible atrial obstruction, yes, measure the fractional expired nitric oxide levels, and if the levels are more than 40, you can diagnose the patient with asthma directly. There is no need of peak flow variability. And if the fractional expired nitric oxide levels are not more than 40, then you have to do the peak flow variability test. And if the variability is there, then you can diagnose the patient with asthma. And even this test is negative, then you have to see if the fractional expired nitric oxide levels are between 25 and 39. If yes, we can even then suspect the patient to have asthma. even if the FeNO values are less than 40, even if the peak flow variability is not there, then also we can suspect asthma, because there is obstruction in the spirometry, there is reversible airflow obstruction. So if the FeNO values range from 25 to 39, we can suspect asthma and give the treatment and review the diagnosis after the treatment. If the levels are not between 25 to 39, and we have to consider alternate diagnosis and refer for a second opinion. And if there is spirometry showing obstruction, but there is no reversible airflow obstruction, then you have to measure the FeNO values. If the levels are more than 40, then you can suspect asthma and give treatment and review the diagnosis. If the levels are not more than 40, if the levels are 25 to 39, then check for peak flow variability. So if levels are 25 to 39 and there is peak flow variability, then also you can suspect asthma and give treatment and review the diagnosis. But if the levels are not between 25 to 39, that is less than 25, then you have to consider an alternate diagnosis and refer for a second opinion. So if the peak flow variability is not there, then we can also test for airway hyperreactivity, that is bronchial hyperresponsiveness, methacholine and histamine challenge. So if it is there, then we can diagnose the patient with asthma. So if the spirometry is showing obstruction, this is not there, and peak flow variability is not there, but levels are between 25 to 39, we can diagnose asthma based on airway hyperreactivity. So in this side part of the algorithm, we can only diagnose asthma with this one, airway hyperreactivity. And the first investigation that we do is spirometry, and that itself is not showing an obstruction. So that means the patient may have asthma. You did not rule out asthma based on spirometry readings, because there is some other tests that can prove that the patient is having asthma. If the patient is not having obstruction, we can directly go and measure the fractional expired nitric oxide levels, because if there is obstruction, the FEV1 will be reduced. So in that case, we can give a bronchodilator and see if there is reversible airflow obstruction. But first of all, if the patient is not having any obstruction, the FEV1 is within the normal range, then you can't give a bronchodilator to see if there is any reversibility. So that test is not done here. We directly go to the fractional expired nitric oxide levels. If it is more than 40, then we can do peak flow variability, and if it is there, then we can diagnose asthma. In this part of the algorithm, this is the way that we diagnose asthma. And if there is the peak flow variability is not there, check for high airway hyperreactivity, and if it is there, we can diagnose asthma in this way also. But if the if the FeNO values itself are less than 40, then check for peak flow variability, and if it is there and airway hyperactivity is not there, then consider alternate diagnosis or refer for a second opinion. But if the airway hyperreactivity is there, diagnose with asthma. I know this is a complicated algorithm, but go through it for 2 to 3 times so that you will be thorough with it, because at any part of the algorithm you can be stopped and you will be asked questions. They will give a clinical scenario followed by spirometry values, followed by airflow reversibility. Reversible airflow obstruction is there. Then what is the next test to diagnose asthma? So they can also ask if there is no obstruction in the spirometry, what is the next appropriate test in the diagnostic algorithm of asthma. So there are many things that can be asked from this algorithm. So go through this. Moving to the next one. So these are the treatment algorithms for children less than 5 years, and for children and young people aged. In Mrcp, they won't expect us to answer questions on treatment algorithm for children and young people. So we can directly go into the pharmacological treatment of chronic asthma in adults aged 17 and over. So, so with this algorithm needs to be there in your mind. all the time. Like it should be there in your fingertips, because they can stop you at any point of the algorithm, then ask the next appropriate treatment, next appropriate line of management, everything. So we started with a patient who is newly diagnosed asthma in adult. So you have to ask for the symptoms. If there are infrequent short-lived wheeze and normal lung function, we can consider a short-acting beta agonist alone. And if the asthma is uncontrolled in 4 to 8 weeks, then we can come back to this algorithm. So this is a small one beside the main algorithm for patients with infrequent short-lived wheeze and normal lung function. So coming to the main one, the symptoms that indicate that there is a need for maintenance therapy at presentation. So there should be a reliever therapy and there should be a maintenance therapy. So we have to start the patient on low dose inhaled corticosteroid with short acting beta agonist. This acts as a main reliever of acute symptoms, and this acts as a maintenance therapy. So if the asthma is uncontrolled for 4 to 8 weeks, we have to move to the next part of the algorithm, where we have to offer the patient a low dose inhaled corticosteroid plus leukotriene receptor antagonist. So these are the new drugs that they have added, leukotriene receptor antagonists, which are drugs like montelukast with a short-acting beta agonist. And then also, if the asthma is uncontrolled for 4 to 8 weeks, then we have to offer the patient a low-dose inhaled corticosteroid plus a long-acting beta agonist. This is the new one added here, with or without leukotriene receptor antagonist, based on the patient's response to this drug. We can even remove the drug if the patient seems to be unresponsive to this drug. And we have to continue the SABA. And if the asthma is uncontrolled for 4 to 8 weeks, we have to start something called as a maintenance and reliever therapy, which is low dose ICS plus long acting beta agonist. So this uh, combination of drugs, which is low dose ICS plus long acting beta agonist, act both for maintenance and reliever therapy. And then even if with low dose ICS and LABA, if the asthma is uncontrolled, we can increase the dose of ICS to moderate dose ICS plus LABA as a MAT. MAT means this combination acts as both maintenance and reliever therapy. Or the patient can be given ICS and LABA as a fixed dose with or without leukotriene receptor antagonist. So when you are using MAT as a combination of low dose ICS and LABA, there is no need of including a short-acting beta agonist. But when you're using them as a fixed dose, you have to consider using a short-acting beta agonist for temporary reliever therapy. So this is moderate dose. Just remember this as moderate dose ICS plus LABA as a MAT. This part of the algorithm. Just remember that thing. That we have changed the dose of ICS, low dose to moderate dose. And if asthma is uncontrolled, even with this, we go for high dose ICS plus LABA as a fixed dose with or without leukotriene receptor antagonist. And as we are using this as fixed dose, we have to give the patient a short acting beta agonist as well. So apart from this option, we can also go into this part of the algorithm, or if we can try this first and then go into this part of the algorithm. So the next one would be continuing a moderate dose inhaled corticosteroid with a trial of additional drugs. There are some other additional drugs that we can try, like a long-acting muscarinic receptor antagonist or theophylline with a SABA or low-dose ICS plus a LABA within a MAT regimen. So if you are using low-dose ICS with LABA, that would be a MAT. That is not compulsory. You can remove LABA at this stage and also continue the treatment with SABA, low-dose ICS, and other additional drug that you will be adding. Or you can go into this part of the algorithm where you consider seeking advice from a healthcare professional with expertise in asthma. So you have to consider changing your decision. You can whenever the patient is having uncontrolled asthma. So the MCQ they will be asking will stop somewhere here and ask you what is the next line of therapy. They will give a clinical scenario where the asthma is uncontrolled and the patient is on low dose ICS and SAVA. Then they'll stop you here and they'll ask what is the next step. They can stop you here and then ask you what is the next step. So please be thorough with the algorithm. And we have to consider decreasing the maintenance therapy when asthma has been controlled with current maintenance therapy for at least 3 months. So 3 months, for 3 months, if the patient has been well controlled asthma is there, then you should consider decreasing the maintenance therapy dose. So this is the treatment algorithm. Coming to the acute asthma, we follow BTS 2016 guidelines as of now. There are 4 things that you need to remember. The levels of severity. There are many questions that have been asked in part 1 on the levels of severity. They give a clinical scenario and ask which level of severity of asthma is this. So there are many questions on this, and then initial assessment, which is important for your clinical practice, not for MCQs. And criteria for admission also is important for clinical practice. And treatment of acute asthma in adults is important for MCQs. So the main thing that you need to focus is on the levels of severity. So coming to the levels of severity in asthma, acute asthma attacks in adults, I've taken this picture directly from the guidelines. So whenever the patient presents with acute asthma, you need to measure the peak flow expiratory meter. Using the peak flow expiratory meter, you have to measure the peak expiratory flow. It is measured as percentage. So the moderate acute asthma is when there is increasing symptoms and the PEF is greater than 50 to 70% best or predicted, and no features of acute severe asthma. So these features of acute severe asthma should not be there to consider the patient to be having moderate acute asthma. So let's go into the next one, acute severe asthma. When the patient is having any one of these 4 things, there should be any one is enough. So the PEF 33 to 50% best are predicted, respiratory rate greater than 25 per minute, heart rate greater than 110 per minute, and inability to complete sentences in one breath. This is because of the shortness of breath. They can't complete sentences in one breath. So presence of any one of these indicate that the patient is having acute severe asthma. And coming to the next one, which is life-threatening asthma. So any one of the following in the patient with severe asthma. Clinical signs and measurements. So coming to the clinical signs, when the patient is having altered conscious level, exhaustion, arrhythmias, hypotension, cyanosis, silent chest, poor respiratory effort. These are the important clinical signs to make the patient diagnosed with life-threatening asthma. This silent chest is important because we expect the patient to have wheeze during the acute asthma, but life-threatening asthma is when the patient's respiratory effort becomes poor, because of which the breath sound itself will become silent. So silent chest and poor respiratory effort are important. The measurements include PEF less than 33% best are predicted, and SpO2 less than 92%, PaO2 less than 8 kilopascals. This is also the important thing that you need to remember, normal PaCO2. So when there is poor respiratory effort, the patient is likely to retain the carbon dioxide. So there will be raised PaCO2. But in life-threatening asthma, the respiratory effort is just enough to clear the carbon dioxide. So the PaCO2 will be normal. So the main difference between life-threatening asthma and near-fatal asthma is this one. The PaCO2 is normal in life-threatening asthma. This is usually low because the patient will be in severe respiratory distress. So the patient will be tachypneic and there will be more washout of carbon dioxide in acute asthma. But coming to life-threatening asthma, the respiratory effort becomes poor and the PaCO2 becomes to normal. From low to normal, uh, it it means that there is life-threatening asthma. But whereas in near fatal asthma, there is completely poor respiratory effort causing raised PaCO2 and requiring mechanical ventilation with raised inflation pressures to treat the patient. So this is how we divide the levels of severity. There are many questions that can be asked from this table. The clinical scenario, they will give one clinical scenario with some PEF value, or they will give the respiratory rate, heart rate, and you need to diagnose the level of severity. But I have seen many MCQs based on this normal PaCO2 and raised PaCO2. The patient clinical scenario will be given where the patient will have silent chest, poor respiratory effort. The PaCO2 will be normal. So if you miss the PaCO2, you can't diagnose life-threatening asthma. And if the PaCO2 is low and the patient's respiratory rate is more than 25, that is one of the clinical scenario that I've seen in the MCQs, where the respiratory rate is high and the CO2 washout is more, and so the PaCO2 will be low. In that case, you have to diagnose the patient with acute severe asthma. When the patient is going from acute severe asthma to life-threatening asthma, the patient retains PaCO2, the patient retains carbon dioxide, so there will be normalization of the PaCO2 when the patient has life-threatening asthma. That is important. So the next one is initial assessment. Just you have to know what all things you have to do when the patient comes with an acute asthma. You have to ask for the symptoms, examine the patient. You have to do an bedside peak flow expiratory meter reading, which shows peak expiratory flow value, based on which you can categorize the patient according to the level of severity. And then pulse oximeter reading, ABG, chest X-ray, and systolic paradox, which is pulsus paradoxus, but it is an inadequate indicator for severity. So just remember, these are things that you need to look into when the patient presents with acute asthma. And then criteria for admission is when the level of severity is high, that means the life-threatening and near-fatal asthma attack, you have to compulsory admit the patient. And if there are any features of severe asthma attack persisting after initial treatment, that is the second level of severity, but it is persisting after the initial treatment, then you have to admit the patient. And patients whose peak flow is greater than 75% best or predicted 1 hour after the initial treatment may be discharged from ED unless they meet any of the following criteria when admission may be appropriate. It means that the patient's symptoms improve, the peak flow has improved, but the patient is still having a risk of life-threatening or a near fatal asthma attack. These are the risk factors which make the patient to have a higher risk for life-threatening asthma. So these patients with these risk factors, we need to admit the patient even if they have improved. So that includes the patient is still having significant symptoms, concerns about adherence, living alone or socially isolated, psychological problems, physically disabled or learning difficulties, previous near-fatal asthma attack despite adequate dose of steroid tablets prior to presentation, and presentation at the night times, and if the patient is pregnant, we have to admit the patient. The next thing is management guidelines for acute asthma. The first one is oxygen therapy. So for a patient with acute asthma, we need to give supplemental oxygen to all hypoxemic patients, and we need to maintain a SpO2 level of 94 to 98. So if there is absence of pulse oximeter, you do not have to delay oxygen administration. You can give oxygen, and as soon as the pulse oximeter is available, then you can monitor the SpO2 values. And the second one is beta 2 agonist bronchodilators. We have to use a high dose inhaled beta 2 agonist as first line agents in patients with acute asthma, and we need to administer these inhaled beta 2 agonists as soon as possible. But we need to reserve the intravenous beta 2 agonist for patients in whom the inhaled therapy cannot be used reliably. So this is something regarding beta 2 agonists that you need to remember. And coming to the steroid therapy, we need to give steroid therapy in adequate doses to all patients with acute asthma attack. We can give them in the form of tablets or injections. The tablets are equally effective as injections, provided they can be swallowed and retained properly. So we can give prednisolone 40 to 50 mg daily, or parenteral hydrocortisone 400 mg daily, which is 100 mg 6th hourly. So these are the steroid tablets and injections that you need to give. And the next one is dipratropium bromide, which is long-acting anticholinergic agent, we have to add nebulized ipratropium bromide to beta agonist therapy that we are already beta 2 agonist therapy which we are already giving in patients with acute severe or life-threatening asthma, or those people with poor initial response to beta 2 agonists. So this is something that can be an add-on therapy that we can give. So magnesium sulfate is the next one. So nebulized magnesium sulfate is not recommended for treatment of acute asthma in adults, and it is only given because it has some evidence that it has a bronchodilator effect. So we have to consider magnesium sulfate IV to patients with acute severe asthma. That is, the peak expiratory flow is less than 50% best or predicted, and who do not have a good initial response to inhaled bronchodilator therapy. So the dose would be 1.2 to 2 grams IV infusion over 20 minutes, and should only be used following consultation with a senior medical staff. So you may be asked some question regarding magnesium sulfate, like uh, they will give the clinical scenario, after which they will ask you which is against which is the thing in the patient that is against starting a magnesium sulfate injection. So they, in the options, they can mention that the patient has improved his peak expiratory flow after admission. So that could be a point against the use of magnesium sulfate, because the patient is already improving. There is no much evidence into this. So there is only some evidence that magnesium sulfate is a bronchodilator effect is there. So in that way the question can be asked. And the next one is IV aminophylline. So this also needs to be used only after consultation with senior medical staff. And there can also be some side effects such as arrhythmias and vomiting. So you need to be careful if you are opting to give IV aminophylline. The next one is leukotriene receptor antagonist. Currently, uh, the evidence does not support the use of leukotriene receptor antagonists in acute asthma. There needs to be further studies that to be done to determine its effectiveness and safety in acute asthma. But in chronic asthma, we used these drugs. So the next one is the evidence of antibiotics. So routine prescription of antibiotics is not indicated in patients with acute asthma. And the next one is heliox, which is helium and oxygen mixture in the ratio of 80:20 or 70:30. But this heliox is also currently not recommended for use in patients with acute asthma outside a clinical trial setting. So routinely this is not used. So previously these were this is used, so I'm telling the recent update that it is not used or not recommended for acute asthma now. And IV fluids, there are no controlled trials in that show the evidence of IV fluids in acute asthma. So, but some people may require rehydration or correction of their electrolyte imbalances. As you know, beta 2 agonists can cause hypokalemia, and so if you want to correct those electrolyte abnormalities, or if you want to rehydrate the patient, definitely you can use IV fluids. There's nothing that can cause a problem because you gave IV fluid. So, but there is no evidence in controlling asthma. And nebulized furosemide is another thing. Theoretically, there is some evidence, but in routine practice, we are not using this. And then, if the patient is critically ill, then you may go for options of critical care settings where you have options of non-invasive and invasive ventilation, mechanical ventilation, and you need to have these patients under critical care monitoring. ICU management will be there. Uh, mostly the patients who have life-threatening asthma will need these kind of critical care settings. This non-invasive ventilation should only be considered in an ICU or equivalent clinical setting, and then the further investigations and monitoring. We need to regularly record the peak expiratory flow 15 to 30 minutes usually after starting the treatment. And we need to also monitor the oxygen saturation by oximetry and maintain an SpO2 of 94 to 98. And we need to regularly monitor the arterial blood gas tensions. Usually it is done within 1 hour of starting treatment. And if the patient did not improve after 4 to 6 hours, we need to again measure these things, that is peak expiratory flow, oxygen saturation, and an APG. And if the patient is on aminophylline, we need to consider the test, which is serum theophylline concentration. Only if aminophylline is continued for more than 24 hours. And regularly monitor the serum potassium, blood glucose, and heart rate as well. And we have to plan the discharge when the patients have clinical signs which are compatible with home management. With reduced amounts of beta 2 agonists, we can discharge the patient. And another thing, which is occupational asthma, as I told you. And in this, the patients may present with concern that chemicals at work are worsening their asthma, or you may notice that the symptoms are worse in the weekdays and better in the weekends. This is suggestive of occupational asthma, and this is the MCQ that you may be expected in part 1, Mrcp part 1. The most common cause is isocyanates, and the other things like platinum salts, smoldering flux resin, glutaraldehyde, fluor epoxy resins, proteolytic enzymes. These are some of the occupational asthma triggers. Isocyanates, you need to remember, the most common cause. In these, the serial measurements of peak expiratory flow are recommended at work and away from the work, so that you can diagnose the patient with occupational asthma. And if the patient is suspected to have occupational asthma, you have to refer them immediately to the respiratory specialist for patients with suspected occupational asthma. So this is all about asthma guidelines and all the theory part that you need to know about asthma for Mrcp part 1 and part 2. So you can quickly revise by putting the video in playback speed of 2x and use your headphones for a better audio quality. I am trying to improve the audio quality, but please bear with me for some time. I will definitely improve these videos. And the next video expected will be on MCQ discussion on asthma, and I'll be also making videos on COPD and pleural effusion in the next upcoming days. And all the best for your preparation for Mrcp part 1 and part 2. Please comment down if you have any doubts, and please comment down if you want me to teach any specific topic. I will be definitely helping you. And please subscribe to my channel. That I would take that as an encouragement to make such free videos which will be helpful to so many people. So please subscribe to my channel. Thank you.